Thomas will be presenting on challenges and recent trends in the management of culture-negative endophthalmitis.
Thank you, Dr. Meena, and good afternoon. We have heard about culture-positive bacterial endophthalmitis, intravitreal cluster endophthalmitis, injection, post-injection endophthalmitis, and now let's go into culture-negative endophthalmitis. Culture-negative endophthalmitis, these are presumed infectious endophthalmitis which pose a huge diagnostic challenge in terms of clinical management. These are not sterile endophthalmitis, just that we did not get a positive culture from our laboratory. A sample is declared culture negative when there is no growth of any organism after 7 to 14 days in any of the culture media. The various studies across India have shown the incidence of culture negative endophthalmitis ranging from 44% to 61%. It also depends on the lab standards which are practiced and many other factors. The possible explanations for culture negative endophthalmitis: sometimes the quantity of the specimen which is given to the lab is very small. There could be a fastidious or slow growing or unculturable pathogen. There could be a prior systemic or topical antibiotic therapy which gives a culture negativity. Sometimes there is a delay in processing the ocular samples. The organisms could be sequestrated in the capsular bag and the IOL. Immunological reaction to scan bacteria, and above all, poor lab practices. The clinical outcome of culture negative endophthalmitis versus culture positive endophthalmitis. Culture negative endophthalmitis has good visual outcome post treatment, which is in a non-infectious toxic insult. Paver et al. Reported treatment success rates of culture negative cases as 60%, and culture positive endophthalmitis lead to change in clinical management intervention compared to culture negative endophthalmitis, where we have to go empirically and based on the clinical findings. So what are the challenges in managing a culture negative endophthalmitis? First of all, is it possible to differentiate from culture positive endophthalmitis clinically? No, because these are also infectious endophthalmitis, and it has been reported that decreased vision, presence or absence of pain or hypopyonovitritis, and interval between surgery and presentation does not help to distinguish culture positive from culture negative endophthalmitis. That is not the criteria. Failure to respond to incorrect or delayed antimicrobial therapy, further leading to severe inflammation and irreversible loss of vision. Non-infectious etiology like sterile endophthalmitis can sometimes mimic infectious endophthalmitis, making the diagnosis challenging. Now, what do I mean by saying poor lab practices? Many of our microbiology labs use blood bank blood for making blood agar and chocolate agar, and in our situation, most of us have used a lot of antibiotics during our lifetime, and the blood bank bloods will also be rich in antibiotics, and if at all you make a blood agar or chocolate agar with the blood bank blood, these would not grow organisms adequately. So the alternative is collecting blood from the butcher in a sterile way. Sheep blood or buffalo blood can be used to make blood agar or chocolate agar. Nowadays they have artificial media, commercially available artificial media, but still never use blood bank blood, but most of our labs still use blood bank blood for preparing these. That is one of the main causes for getting culture negativity. Diagnostic approach in culture negative endophthalmitis: the comparative assessment of cytokines in culture negative endophthalmitis. Vitreous sample analysis of 16 immunomediators as biomarkers was done, and the result indicated that culture proven and culture negative vitreous samples have similar cytokine and chemokine profiles. However, immune mediators like IL, IR1, RA, alpha, and all these have exhibited a significant difference between the culture negative and control group, which was postulated to serve as biomarkers for diagnosing culture negative but presumed infectious endophthalmitis. So this is the flow chart how we manage when we get a vitreous sample. Vitreous sample we send for a smear examination and culture identification. If you get a culture positivity, you do the antibiotic sensitivity. Meanwhile, we would have injected the first line of intravitreal antibiotics, and based on the culture positivity and the antibiotic susceptibility, antibiotic sensitivity, we change the antibiotic as and when required. But when we come to culture negative endophthalmitis, we don't get a positivity, so we go by molecular diagnosis, PCR or next generation sequencing. Sometimes we have to do a real-time PCR, and also biomarkers, the bacterial biomarkers and the fungal biomarkers might help in giving a clue as to what you are facing. The molecular diagnostic techniques, we have real-time PCR, the pan-PCR, and the next generation sequencing. PCR is recommended in culture-negative endophthalmitis where empirical treatment fails. PCR and standard cultures are complementary in microbiological identification. PCR offers an advantage of detecting organisms in samples obtained after treatment with intravitreal injections also. So if the patient has taken an intravitreal injection and come to you, your culture might not yield any growth, but your PCR might yield you a result. PCR can detect organisms in pure or diluted samples in 72% and therefore is the gold standard. PCR analysis is the amplification of DNA of microorganisms in clinical samples. We have the pan-bacterial PCR and the pan-fungal PCR. However, a negative PCR does not exclude the diagnosis of culture-negative endophthalmitis because, again, the sensitivity of PCR is not 100%. When we have a sample, what sample should you take for PCR? We can have an aqueous tap or vitreous biopsy. However, a vitreous biopsy is the best sample because the aqueous quantities are low and the yield is low. Sample has to reach the lab in 2 hours. And if there's a delay, the PCR tubes have to be stored at 4 degrees Celsius for a maximum of 48 hours or minus 20 degrees Celsius if it is longer. Real-time PCR measures copies of DNA in a sample made using a microorganism specific primer. The turnaround time is 2 to 3 hours. The sensitivity and specificity are very high, but sometimes you might get false positivity because there could be a contamination which could again be positive. Unlike a pan-PCR, which takes around 2 to 3 days, and it's unable to detect viruses and parasites. The advantage of PCR, we need only a small sample. There is a rapid identification. It can identify the pathogen's DNA even if it is dead or hard to grow. It identifies specific pathogen. When the specific pathogen is unknown, pan-bacterial and pan-fungal PCR can be used. It can even be used in eyes where intravitreal injection was taken. The disadvantage is not a first-line test. If you get a culture positivity, that is the gold standard. The reagent and equipment are expensive. It can give false positive results and sometimes it can miss some infections. What is next generation sequencing? It can detect different fungi or bacteria present in clinical samples in one single assay. It detects not only the traditional organisms associated with endophthalmitis, but can also identify the newer organisms. Faster results are available than when a pan-PCR is negative. The galactomannan and 1,3-beta-D-glucan, these are polysaccharides. This cell wall component of Aspergillus and filamentous fungi are detected. This can be used as biomarkers in culture-negative endophthalmitis. And what is the treatment of culture-negative endophthalmitis? Just like any other post-surgical endophthalmitis, we take a vitreous biopsy, we do a vitrectomy, we inject the intravitreal antibiotics. In culture-positive cases, treatment decisions and management is altered as per culture reports, while in culture-negative endophthalmitis, we don't have that cushion. We have to go by PCR and NGS and also by the clinical findings which we have. These are the primary antibiotics which we use in managing endophthalmitis: vancomycin, ceftazidime or amikacin as the case may be, and antifungals, amphotericin and voriconazole. These are our first-line antibiotics even today. But in culture-negative endophthalmitis, if your patient doesn't respond to these first-line antibiotics, for gram-positive, we can use linezolid, quinapristine or dalfopristine, daptomycin and tigecycline. And for gram-negative, imipenem, ciprofloxacin, levofloxacin and moxifloxacin can be used. Piperacillin and tazobacter are used in gram-positive and negative and aerobic and anaerobic. And for fungi, you can use miconazole, capsofungin and micafungin where it is resistant to your voriconazole or amphotericin B. To conclude, in spite of limitation of low yield and inability of certain pathogens to grow on routine media, microbiological culture still remains the gold standard for the diagnosis of most intravitreal infections. And the use of molecular diagnostic technique has improved the yield of detection in addition to reducing the time in making confirmatory diagnosis in culture-negative endophthalmitis. Thank you.